Hey, good evening. This is Dr. Mark Sackel, a practicing and internist in Nevada, who with you today in my role as Chief Medical Officer of Meritage Medical Network. This lecture directed at urologists and gastroenterologists about the risk programs that we are here at Meritage and how to assess high-value codes properly. Collected you two together because most of your high-value codes have to do with cancer, and things are fairly similar. There's a few definitions which you may or may not know and may or may not have been at some of my training sessions. The most important terms are RAF, which is short for Risk Adjustment Factor. And this is a conglomerate of high-value conditions and demographics that identifies how sick a patient population or patient is. And what that allows us to do is compare one physician group's patients to another, or even one patients to another. My practice might have a higher RAF as a geriatrician with 50 to 70% Medicare than a family practitioner who has 20% Medicare. That way, we can actually basically adjust for the more difficult patients or for them appropriately. The RAF is comprised of demographics and HCC codes, which are hierarchical category codes, which assign a point value to the property bill diagnoses that add up to the RAF. Which ones are relevant to you? Mostly those related to cancer, I would say. GI has a few others, ostomy or a couple of others as well. What does it really mean? This is very important for all of you, and I've read many of your notes, and many of them are brilliant. Many of them are brilliant but hard to decipher, but they be in a certain format ultimately. You need your diagnosis clearly identified, which can code and or written. You have status, which is how you came to the diagnosis or how the patient's doing, and your plan. If not the way, you will not pass audits. And then the payer calculates the RAF and demographic factors, adjust them to an average score of 1.0, which means the average RAF value for a Medicare patient in the United States is 1.0, and then pays the physician substantially based on the RAF. And this payment comes post-facto. So you can get an enormous bill 1 to 2 years after you've done your work. So how actually the intensity with which physicians document varies across the country. The data shows that the sickness of the patient, let's say the adjusted RAF on the y-axis, matches up with the unadjusted risk. That means I look at your chart before you see the patient, I figure out which codes, and then I see if you documented them. So that is where we should all be. But I look at the doctors in St. Paul, Minnesota, they code more intensively and apparently on audits correctly, so they will get more out of money for the same conditions that you were treating. We are doing better than McAllen, Texas, which actually undercodes and is basically herniating dollars from the Medicare payers. And Sonoma are somewhere towards McAllen, Texas. And if you look at it, darker blue teal states, some have, particularly in Minnesota, it looks like, in Michigan, Rust Belt, Montana, Idaho, places that really vote for our president, see the code very intensively and know where to find the money. The blue colors, you see that there's a particular cluster in areas of Florida and in the Bay Area, code less intensively. What this means is that for the same conditions, doctors, Sonoma doctors, will get up to 20% less than doctors in the Mayo Clinic in Minnesota. They do fabulous coding, I've seen their notes. Why is RAF important? It levels the playing field. It allows us to basically normalize the sicknesses of our practices and of our patient groups and allows comparative studies. It basically identifies 5 RAF score patients who might benefit from case outreach. So we have a patient with a RAF of 1.8, and it's a Meritage patient. We will contact that patient to see if we can help them manage their care. Rather than underwriting risk, which is before you see the patient, it is a post-facto way of adjusting payment to the risk as documented by the physician group. And the higher the population RAF, the more revenue for the physician group that we'll receive in a year, half, or two. And this is important. We don't have, people are getting older, but the proportion of Medicare Advantage patients, which is the fastest growing part of Medicare, is basically gobbled up by Kaiser in our counties. We can get them back, but if we get them back, we have to break even or make money on them. So we've done apropos money. Well, in 2018, before we started outreach to physicians, we lost $2.5 million and 5,000 patients. That is a big piece of change. We sent out primarily to primary doctors, and by December 16th, we had staunched the hemorrhage, and we think we did break even on the scan, which is our Medicare risk population. This year, we are pretty sure, and it will be validated next year, that we made $2.5 million on these patients, and we have to achieve a RAF of 1.0, which is a RAF for Medicare patients by the end of this year, and that would net us up $3.5 million. And I've said this often in my talks, that Taj is not an insurance company. We're an IPA. We're a physician-run and led organization. Most of the money, historically at least 80%, and last year more, goes back to physician incentive bonuses, and you should have received a payment last year, or you'll be sure. Okay, so the name of the game is to identify the cylinder. The dark blue is the risk that you have documented, prostate cancer. The actual risk is prostate cancer plus prostate cancer metastatic to bone, which you haven't specifically diagnosed with an ICD-10 code will not get picked up. We want to narrow that gap, and that's why I'm out reaching to you. I guess. So here's an example of a lady with neither GI or urologic conditions. Oh, no, she does. She's got Crohn's disease. She has Crohn's, which I'm sure you won't miss. She's got depression because she has Crohn's. She has RA. She has functional quadriplegia, which means she's so debilitated she's a two-person assist to get up from the chair. You add all those things up. She has an HCC risk factor of about 1.6. Since old, she's about 0.8. And when you do math and adjust it, she is got F 2.2 or 2.3. We talk to her to see if we can help her with her medicines and compliance. And the plan will get back about $8,000 per year for taking care of this lady. So let's here just review how you should be documenting whether you like it or not. Many of you have very intelligent prosaic notes, which is fabulous. But when you come to the gist of the problem, you need to say what the diagnosis is, what the status of the patient is, and what your plan is. So Crohn's disease this is increasing symptoms interfering with quality of life plan, consider biologic therapy. A new diagnosis, it could be Crohn's disease, made the diagnosis based on recent colonoscopy, plan, see the office to discuss treatment options. That's what you have to do. So each one of your problems that you identify, that's what that is. So if GI cancer, you do for adenocarcinoma of the colon, and then you write a second diagnosis, metastasis to the bone, painful plan to see XRT. Those are two things, and that's really the gist of the talk for documentation. I have physicians who will do one-on-one sessions with you who seem to be good, or I can do one-on-one or one on a couple sessions to kind of this, because this is actually very, very important. Again, 3 components of documentation. If it's a new diagnosis, so alcoholic cirrhosis of the liver, how you came to that diagnosis, lab results, let's say, or ultrasound, however you came to it. Plan what you're going to do about it. Go to AA, continue abstinence, start aldactone, start whatever drugs, rifaximin, whatever it is you're doing. If it's an existing diagnosis, try to find a diagnosis that is HCC, and we'll give you a list of diagnoses that seem relative to your so that you haven't received it. So if someone's depressed and they're on medicine, they actually have major minor depression. And, you know, if you're really treating them or involved with their care, you know, some of the GI people and depression, then to code major minor depression rather than depression. Status evaluative statement, how are you doing? Stable on Prozac, plan, what are you going to do it? Follow-up PCP, follow-up psychiatrist. Diabetes is common to both of your specialties, and diabetes is a gold mine. If you have diabetes, that's an ACC code. But if you have diabetes with something, it's also an ACC code. If you have erectile dysfunction and you're otherwise healthy as a man, it's not worth any extra money to us. But if you have erectile dysfunction associated with diabetes, which is a specific code, that is a gold mine. Document not just ED, but ED secondary to or associated with diabetes. Estimate inadequate erections, plan trial of Cialis. Saying if you have dyslipidemia, if you have peripheral vascular disease, if you have gastroparesis, if you have anything in your specialty associated with diabetes, including X, which is not your specialty, please document it as well as whatever it is that you're treating. So link the two diagnoses. Example of coding for gastroenterology. You see Crohn's disease with and without complications, IED, and we give you some coding tips there. Celiac, we have psoriasis, and it's to use, I'm sure as you know, a high degree of specificity in terms of audits and whatever they want for our lives. Chronic B and C and so forth. These are high value codes as well as the cancer diagnoses I've talked about. Duodenal obstruction, I guess we don't see that often. Pancreatitis, I don't think these are things you're going to miss, normally speaking, but you have missed really identifying malignant neoplasms with a degree of specificity, as you see for the neoplasm of the esophagus. The prostate we have, you see prostate cancer is a pretty low value code compared to kidney disease, which is worth twice what a prostate cancer is. But if a secondary malignant neoplasm of the bone, either, I guess both these cancers go to bone, that's worth 10 times what the primary cancer is. Okay. A lot of our special patients, the primary Medicare is defined as being on medications or the clinician with an intelligence scoring system thinking that you have depressed, just coded as major depression. If someone is drinking too much alcohol, and this is important to assess, particularly preoperative, since you don't want surprises postoperatively, alcohol dependence. If someone was an alcoholic in the 1980s, they are still alcoholic, the disease is doing push-ups, that's what they say in AA. Now, document alcohol dependence and remission. That's a high-value code. And the thing for opioids, if someone's on chronic Norco for chronic pain, probably you're not prescribing that, but if I am, I should be doing that. Okay, we doing to help for this code appropriately. Let me just point out that of our 30,000 patients, about 80% have some degree of risk. Sometimes we can lose money, that's particularly on Medicare Advantage and WHA, which is our largest commercial plan, 15,000 members. Some we just have a little bit of upside, which means that proper documentation is key to getting our value from the payers for the work we do. So PCP, we basically will look at their upcoming physicals and identify what codes look juicy, and we'll let them know, and then we'll incentivize them to actually capture them if they're appropriate. We will actually send nurses out to make home visits, and you can ask us to do this. You know, just me or the case manager, and we will go in and do that if you think someone would benefit from a visit and as a meritorious patient or scan patient. The first step is RAF Education WebEx, and there's a very difficult test upcoming for you. This is worth a point towards your 6-point incentive bonus this year, and you have to have completed this to get any incentive bonus. Last year, the points were worth about $800 for specialists, so 6 times 8. So, you know, you can get up to about $5,000 for doing an incentive plan for specialists. If any of you want in-person education, we are happy to give it. It's also nice to have in the practice one person who's expert, so that person can disseminate the information. And we have coding guides that we can share with you if we haven't already. I expect them to have been shared, but after this talk, people realize they don't have them. Study. A 65-year-old man who was an alcoholic and stopped drinking 3 years ago. Type 2 diabetes, Cialis for EE, PH9, which is a depression, say, is positive, and also colitis. These are medications, metformin, Cialis, sertraline. What we diagnose and E associated with diabetes. Just don't put ED. All right. So for urologists, that's important. Anything you can add to diabetes, put in diabetes. Diabetes and ED will come up on the encounter form. Major depression. Alcohol remission, that's important for all surgical specialties. I think an alcoholic screen is an important part of pre-op work, and inflammatory disease without complications. So this up, his normalized RAF is about 1.567 per the group per year. One of the things I neglected and should have done in the guides is to point out that whenever you have an ostomy, I don't know if cubic counts. I think it might also, but maybe not. But colostomy, ileostomy, tracheostomy, once per year, documented status. So presence of colostomy is actually a diagnosis code for it. Assessment looks functioning normally, plan, continue ordering dressings. Once a year. If you do it in 2018, on January 1st, Medicare will think the colostomy has closed or there's primary anastomosis until you document it again. This is something the primary doctors will forget. So the holes you make in patient's body, please document once per year. Summarize why aggravation work. Let's get financially recognized, and that financial recognition will also allow us to keep these risk patients and not go to these integrated health systems such as Kaiser, where they just so much better than we do because it's all on one EHR and doctors tend to listen more. Second, I think I would invite you to, from now on, ultimately notes document the way I suggested with diagnosis, status, plan for each particular problem. Note that for us as a physician group and IPA, we can help measure these patients if we identify high RAF scores for individuals. And every time you'll find diagnoses that you had missed before. So many of us, and not all of us, are getting older, and this is a new trick. High flush crowd, Rex tried to remain focused. Still, he could shake one nagging thought. An old dog, and this is a new trick. This is a trick that pays off definitely in terms of being able to manage these patients, get properly reimbursed, and there's evidence that it also improves some quality metrics. So for your time and attention, please contact me by email or call or text or whatever. If you have any questions, and we can get more training and more coding guides if you like. Thank you very much.